beautiful day, Wednesday, May 20th, really nice spring day. And one of the signs that we're getting back to normal is today's journal club is not on a COVID related topic. But I do want to make a few announcements. Again, a sign that spring is in the air and things are going back to normal. Chris Pummel is the CCU fellow, has 10 cases there. We thank Sal Silmy in the Department of Medicine for stocking it with residents, and Chris is teaching them, they're learning, and it's a good educational unit, as well as great care being provided. So thank you, Chris and the fellows. I do want to congratulate several of our fellows and incoming fellows in having been elected to the AOA fraternity. It's quite an honor and distinction. The AOA is the Honor Society of Medical School and Medicine. Josh Kiss was elected this year as a fellow. Anton Kamaj as a medical resident, and Sal Beanstalk as a medical resident. So that's really quite an honor and distinguishing feature for our cardiology fellows. So congratulations. I wanted to just make, let people know that on May 21st, in our continuing sort of synthesis with our sister institution of the Cardiovascular Research Center, and Kevin Costa wanted to congratulate him as the acting director. He's started a very good series of conferences on Thursday at 4 p.m. This Thursday at 4 p.m., May 21st. We're privileged to join them for a Zoom conference with Joe Hill, who's professor and distinguished chief in cardiovascular disease at Texas Southwestern. His topic is heart failure and preserved ejection fraction. I just wanted to introduce today's moderator and speakers. Roxana Mehran is chair professor in cardiovascular research and clinical trials at the Zena Michael Wiener Cardiovascular Institute. She is internationally renowned as a clinical trial specialist, complex data analysis and outcome research in the field of interventional cardiology. She has led the Cardiovascular Research Foundation annual research meetings. She's been on the editorial board of every major cardiovascular journal. And with the Twilight study, which has generated tremendous interest around the world, she's really solidified herself as one of the leaders in interventional cardiology. I also wanted to welcome, is Usman on the line?
Hi, Dr. Goldman. Hello, everybody.
Good. So people may remember Usman Baba. We certainly do. He was such an important part of our program and of the fellowship. He left us just as Corona was joining us. He's currently Director of Interventional Cardiology, University of Oklahoma Health Science Center. He's Director of the Cardiac Catheterization Laboratory, University of Oklahoma, Associate Professor of Medicine, University of Oklahoma. He had completed his internship in residency at Southwestern Texas. He had confided in me it was so difficult leaving his family here, but he was joining his family, his brother and parents in Oklahoma, and that was the major draw. But he's going to generate a tremendous center there and continue his collaboration with Dr. Mehran and other leaders here at Sinai. I also wanted to welcome Mauro Chiarito, who I probably just destroyed his name. He's at the Humanities Research Hospital in the metropolitan city of Milan, Italy. He is an international leader in the field of interventional cardiology, extraordinarily well published. And we thank Dr. Mehran for inviting him, and we thank him for joining us. I'm going to give the physical moderating to Roxana. Please proceed. She has a tremendous meeting for us, so please. Dr. Mehran.
Thank you, Dr. Goldman. Thank you, Dr. Goldman. Thank you all for having me and placing a highlight on Twilight. So thank you very, very much. And I want to welcome, of course, Usman Baber and Mauro Chiarito is a fellow who will be joining us for at least a year, if not two. He was here actually during the corona and returned back to Milan, but hopefully we can get him back. And then, of course, we have a guest panelist, Giulio Stefanini, who's Associate Professor and Director of Cardiovascular Research at Humanitas Cardio Center, which has been a wonderful collaborating center where we have lots of fellows coming through and have a close collaboration. And I'm thrilled to have in our panelists our local experts, Drs. Fuster, Sharma, Kini, Stone, and Dangas. So let me begin first and foremost by giving you my disclosures personally here on this table, but importantly that the Twilight study was sponsored, and we should be very, very proud, by the Icahn School of Medicine at Mount Sinai. This would never have been possible without the support from Dr. Fuster, Dr. Carney, and the Dean's office to allow us to actually sponsor this investigator-initiated study that was funded by AstraZeneca. So how did we start with this? Why was this even an issue, and what made us make this design? There are important clinical issues with aspirin, and I think all of us have seen this over the years, but we feel very, very happy and strong and comfortable with aspirin. That's a cheap drug that has had a lot of good outcomes, but we now have new drugs that are being stacked on top of aspirin, and we're starting to see that there are important treatment failures like aspirin resistance, drug-drug interactions, the COX-1 pathways, the medication non-compliance, premature discontinuation, and an important irreversible but weak platelet inhibition. And we have seen this culminate into gastrotoxicity by sloughing the GI mucosa, and important bleeding risk that we are seeing with almost everything in anticoagulation. And then very important work by Paul Armstrong, where he actually looked at what happens when you have presence of a P2Y12 receptor blockade. What does aspirin do on top of that? And in fact, if you can see from this important platelet function study that in aggregation speaking, there's no significant difference when you have prasugrel alone, this potent irreversible P2Y12 inhibitor, versus if you actually have aspirin on top of prasugrel. So there's no added benefit. And what we do know about aspirin is that there is a very, very important side effect of both extracranial and intracranial hemorrhage that is associated even with primary or secondary prevention. While there is a very good reduction of ischemic events with secondary prevention, there is definitely more bleeding, both extracranial and intracranial hemorrhage. Importantly, we saw this year, 2019, this past year, some really, really null results with primary prevention and aspirin. And we don't have time to go through all of those data, but it is important to make sure we don't forget that. Some 10 years ago, I worked with Dr. Stone on this importance of bleeding versus myocardial infarction. How do we balance ischemic and bleeding complications? And this work done by the two of us really showed the importance of bleeding, especially when there's a transfusion, and how it attributes to long-term mortality. And while myocardial infarction is very important, so is bleeding, especially if there's a transfusion. This is data from the Acuity trial. And then other investigators have also worked on larger data sets looking at acute coronary syndromes here in the TRACER trial, showing this yin-yang of myocardial infarction and bleeding, And it really is very, very important to take a look at that. And major bleeding, you can see here with minor bleeding, it's very, very similar. Major bleeding and myocardial infarction are both really, really important. And when you get to major significant bleeding, like BARC 3B, C, and above, you start to see that bleeding wins. And so how do we decipher that? Keep that in mind. The Plato study is the study that gave us ticagrelor as an approved drug and an approved indication for acute coronary syndrome by this 18,000 plus patient study, where there was a significant benefit of ticagrelor over clopidogrel in patients who presented with an acute coronary syndrome, whether it was non-STEMI or STEMI. And in this study, there was a significant reduction of cardiovascular death, MI, and stroke. There was more bleeding, non-CABG related bleeds, but remember, here, both arms did have an aspirin strategy. So there was a very good analysis. And in fact, in this study, the high-dose aspirin combined with ticagrelor was associated with a significant harm. It was the highest level of events for stroke, myocardial infarction, and death. The best possible result, and where there was a significant benefit, was in low aspirin. And in fact, if you think about this, there is a black box warning in combining ticagrelor with a high-dose aspirin. So if less is more, will none be better? That was the big question. That had never been answered before. And in fact, this is a JACC editorial that Dr. Fuster asked Stuart Hocock and Bernie Gersh put together. And there was a major recognition that maybe we need trials that withdraw rather than stack therapies on top of old therapies. And we need these clinical trials to investigate whether or not taking away established drugs like aspirin could show harm, benefit, or a null effect. And it was a I think it was a very telling editorial that was also coming out around the same time. So it really begged the question, can we safely withdraw aspirin after PCI when novel, more potent P2Y12 inhibitors are used? I can understand with clopidogrel, I would be a little nervous because there are non-responsive patients. But what about when you have a potent P2Y12 inhibitor on board? And that really set the background for the Twilight study. Balancing the ischemic and bleeding complications after PCI, addressing that clinical imperative of lower bleeding while preserving the ischemic benefit meant that we had to look at therapeutic strategies that decouple the thrombotic from the hemorrhagic risk. So can we reduce the duration of aspirin after PCI? And will that allow us to use a potent agent for a more prolonged period of time rather than shortening the potent P2Y12 inhibitor? Can we take away aspirin? Well, we hypothesized this by saying that in patients undergoing PCI who are at high risk for ischemic or hemorrhagic complications, who have completed a 3-month course of dual antiplatelet therapy with ticagrelor and aspirin, continued treatment with ticagrelor monotherapy would be superior to continuing with ticagrelor plus aspirin with respect to bleeding, clinically relevant bleeding, and it would not cause ischemic harm. It would not lead to ischemic harm. That was the trial hypothesis. So this was a randomized, and we felt it was really important for it to be double-blinded. For a drug like aspirin, we absolutely needed to blind the patients, the doctors, the coordinators, everyone. With a placebo-controlled trial in 187 sites across 11 countries around the globe. This was all made possible right here at Mount Sinai, with the Icahn School of Medicine behind us as the sponsor, the contract office. Can you imagine 187 site contracts all went through here. Patients undergoing successful PCI with at least one locally available and approved DES in whom the clinician felt, I need to put this patient on ticagrelor and aspirin at the time of discharge. But then we asked one more criteria in order to get in. We wanted presence of at least one additional clinical or angiographic feature associated with an ischemic or bleeding risk. And these are included here: elderly, female patients, troponin-positive ACS, established peripheral vascular disease, diabetes or chronic kidney disease, and an angiographic criteria that included multivessel disease, bifurcation stents, calcific lesions requiring debulking, all kinds of really difficult anatomic reasons why you might want to put a patient on a potent P2Y12 inhibitor, ticagrelor. Very important is the list of exclusion criteria. Twilight is not for everyone. We excluded prior stroke. We excluded STEMI patients because we just really, it was the very first time that anyone would withdraw aspirin from this patient, all comers almost patient population. So we really wanted to be very, very clear to understand who is not included. And this is an important list. So take it down, and I'm happy to share slides with everybody. We enrolled 9,006 patients across these 187 sites with an open label aspirin ticagrelor, followed for an entire 3 months. Patients came back for a 3-month visit, at which time their adherence to aspirin and ticagrelor was assessed. If they were adherent, if they did not have clinical events such as major bleeding or an ischemic event like stent thrombosis, death, MI, or stroke, they were eligible for randomization. Finally, we randomized 7,119 patients across these sites around the globe and actually were able to evaluate and get the full follow-up at 12 months after randomization in 99.7% of the patients. We lost hardly anyone to follow up. And this was, again, another incredible work of our center, of Usman working with me, and we did this together, exactly equally. As the chair of the clinical coordinating center, he made sure all of this was done. Here's the primary endpoint. If you leave patients on aspirin and ticagrelor after 3 months of them doing well, the incidence of BARC 2, 3, and 5 bleeding is 7.1%. By dropping aspirin, you have an absolute risk reduction of 3% down to 4%, with the numbers needed to treat of only 33 patients to gain this benefit of reducing bleeding by 44%, a 44% reduction, very significant. And important, the most important is, what did we do with the important death, MI, and stroke? Did we cause harm? Well, here's the harm. Absolutely none. There was no difference in the rate of the primary endpoint of death, MI, and stroke. And it is important for you to note that we showed that significant reduction of bleeding, not just in the minor bleed, but also in the important major bleeding of BARC 3 and 5, PIMI major bleed, PIMI minor bleed, Busto major bleed, all of that was reduced, and there was absolutely no difference in the ischemic outcome. So we concluded that in high-risk patients who underwent PCI, treated with aspirin and ticagrelor for 3 months, without any major events with ischemic or bleeding, an antiplatelet strategy of a monotherapy of a P2Y12 inhibitor, ticagrelor, resulted in substantially less bleeding than having the patient on ticagrelor plus aspirin without increasing ischemic events over a period of 1 year. We were very, very grateful to all of the investigators, and this was published in the New England Journal simultaneously with our presentation of the late-breaking trial at the annual scientific T2T meeting, and Dr. Barber and I co-first authored this New England Journal article. But this was a very important finding, and that was really sort of the main finding. But can we provide the mechanistic basis for our observation? And what better place than Mount Sinai with Dr. Sharma, who actually enrolled and randomized 128 patients here at Mount Sinai, with Dr. Juan Badamon, Dr. Fuster, working on the Twilight platelet sub-study. And what better person than Usman Baber to take you through all of the important sub-studies of the Twilight trial. He's currently the Director of Cardiovascular Laboratory and Interventional Cardiology and the Director of the Interventional Cardiology Fellowship at the University of Oklahoma Health Science Center. I am so proud to have Usman Baber, and aren't we all so proud to see him in this wonderful new position at the University of Oklahoma, and we welcome him back to take us through the sub-studies. Dr. Baber.
Thank you so much, Roxana. It's so wonderful to be with everyone virtually. You know, it was a crazy time to leave, and I'm so glad to see everyone virtually in this way, and I can't wait to hopefully come and see everyone in person. Thank you so much for the invitation, and I will go through some of the sub-studies and the platelet sub-study. And Roxana, if it's easier, I can just take the screen just for the next few minutes and do that.
I don't know if you could take the screen. I'd love for you to take the screen. I don't know how to do that.
If you just hit
I can do it.
on the bottom. Just hit
Go ahead. Go right ahead. Please take it on.
Okay. Good. So there we go. So I think you have to let it go and I'll take it.
Stop share?
Yeah, you stop share?
Yes, Roxana, stop share.
Okay.
Perfect.
Thank you.
Perfect. And I will now share my screen. There we go. Okay. Can everyone see, I guess, my screen? Perfect. So
yeah, can you put it on full screen so we
there
just
we go.
see that and not all the rest of the slides?
There you go. So as Dr. Mann's gone through the main clinical study, the rationale, you know, embedded within Twilight were a handful of pre-specified studies that we've been very fortunate to work on and present. One of them, perhaps in many respects, the most important was a Twilight platelet sub-study. When we were putting the trial together, we thought this would be a great opportunity to collaborate with Dr. Badamon and take a look at blood thrombogenicity in patients who were receiving ticagrelor monotherapy. As part of the biological rationale for this trial, there have been a host of largely, you know, in vitro studies in healthy volunteers suggesting that when you add aspirin to P2Y12 inhibition, you don't further augment platelet aggregation or platelet inhibition. So with this platelet substudy, we thought we would do this using a validated assay. This is the Badamon perfusion chamber, which anyone from Sinai is very familiar with, and this time doing it in the setting of a nested study within Twilight. So the way we did this is basically we took patients who were randomized at Mount Sinai, so there were 128. We approached them at the time when they were on stable ticagrelor plus aspirin. So when they came in for their three-month visit and they were doing fine, we actually drew their blood, and we drew their blood to do both the perfusion assays and to do platelet aggregation studies. Patients then, per the trial protocol, either continued on ticagrelor alone or ticagrelor plus aspirin. And then a couple of months later, we had them come back again to do another perfusion assay and repeat platelet aggregation. And so the whole idea was to understand what happens to blood thrombogenicity when you indeed withdraw aspirin and just maintain a strong P2Y12 inhibitor as a backbone. And our hypothesis on the ischemic side is that we would be non-inferior. And we felt this physiologic substudy, if we found no difference, would be a nice corroboration and provide a mechanistic rationale for the lack of thrombotic events that we were anticipating would occur in the clinical trial. And we thought coupling this physiology with the large clinical study would also help support adoption of this strategy if indeed it was positive. And so this is how the study was done. Again, patients, when they were on stable TICA plus aspirin, 3 months after enrollment, came in. We approached them. We asked if they wanted to participate. And in the Batamon perfusion chamber, you cannulate the antecubital vein. Blood is drawn under shear stress in a temperature-controlled water bath. And these are basically thrombogenic substrates that are put in series here. And the thrombogenic substrate in this case is porcine aorta, where the tunica intima has been stripped off. So thrombus literally forms right here on these substrates in this manner. This goes on for about several minutes. And once that's done, those substrates are taken off, they're processed, and then we literally quantify the thrombus. This is a picture of what this looks like. So the purple represents thrombus, and these linear strands are basically the media. So you can actually quantify the amount of thrombus that's being generated in an ex vivo fashion, and you can actually get an area, and that literally tells you whether or not one group has more thrombus as compared with another group. And so these were the results, and we used ANCOVA, analysis of covariance, to examine this. So just to walk you through this, what happens here, this x-axis represents the area that we've quantified in square microns when patients were randomized. This is, of course, when they're on stable ticagrelor plus aspirin. So that's at time 0. And then this is the follow-up. So this is when they come back, and now we've measured the thrombus area a second time. This solid diagonal black line represents a line of no difference. So if your thrombus area at time 0 is the same as it is when you come back, you'd be right on this black line. And one can appreciate just visually that the vast majority of these circles in these dots are right clustered around this line of no change. There's a handful of outliers here, but largely you can see really no difference over time with respect to thrombus area. And when you formally quantify it, you can see that the difference in thrombus area was only 200 microns. There isn't a validated threshold of how much of a difference in square microns using this assay correlates with thrombotic events. However, we do know, based on prior studies Dr. Batamon and others have conducted, that when you give antiplatelet agents that have a clinical effect, you get a reduction in thrombus area of at least 1,000 or so microns. So we're well below that number. The confidence interval crosses 1. The p-value is non-significant. And so what this tells us, both visually and quantitatively, is that when patients are given ticagrelor and you withdraw aspirin, there is absolutely no change in the amount of thrombus that one is able to detect using the Batamon perfusion chamber over about a 1 to 2 month time period. And so the way we interpreted this really is at the last bullet point here. We felt that this finding from a physiologic study really corroborated the clinical observations Dr. Mehran has already alluded to of no incremental ischemic risk once we withdrew aspirin, seen in the large parent trial. And again, I think this helps kind of support the strategy from a scientific standpoint, that when we're getting rid of aspirin, we're not causing any incremental propensity for additional thrombosis. So that's a platelet sub-study that was done here, and we were able to present these and publish this in JACC. We've had a couple of other.
Dr.
Yes.
Just want to make sure we have only like another 15 minutes, and we want to get to that important meta-analysis that we have our papers on. So if you could go through this as fast as you can, that would be great.
These I'll go through in literally 5 minutes or less. So the Twilight ACS, we had about 2/3 of our patients had acute coronary syndrome in Twilight. You can see here, this is a common theme. When we withdraw aspirin in the blue, we see a large reduction in bleeding, about 50%. And of course, in the ACS population, we're going to be concerned about causing excess MIs, and you can see no differences in thrombotic risk. So this is an important pre-specified analysis. Diabetes, this was presented by Dominic Angelillo at the virtual ACC. So here you can see the about 40% or so patients in Twilight had diabetes, and this is their breakdown. And just getting to the meat of it, again, common theme when you look at the bleeding events, diabetic or non-diabetic. When we withdraw aspirin, we see large reductions in all the different types of bleeding. But again, the question is what happens from a thrombotic standpoint? And you can see here on the left, when you withdraw aspirin, there's no excess risk for death, MI, or stroke. So we're seeing both in the acute coronary syndrome population where you have elevated risk, here in the diabetic population, in both groups, when you withdraw aspirin, we're seeing no excess risk for thrombosis in either cohort. And then the Twilight complex, using in about 1/3 of patients complex procedures in Twilight, and we basically adapted the definition that Gennaro Agostino had previously published. And using that definition, we found, again, with respect to bleeding, you see large reductions. And again, with respect to thrombotic events, that's the key concern. You can see no excess risk for thrombotic events here. So again, the theme is common, irrespective of clinical determinants, diabetes or ACS, or angiographic determinants here with complex. We're seeing no penalty to be paid when we withdraw aspirin. And then finally, the synergy analysis. This was a pre-specified analysis just presented at the SKY virtual sessions, where we looked at patients who had a biodegradable polymer drug-eluting stent. This is the synergy platform. There are data to suggest when you use biodegradable polymers, you may gain an advantage both with safety and efficacy. So we took the opportunity to take a look at the patients in Twilight and compare those who received the synergy biodegradable polymer DES, that was about 650 patients, compared to the quote-unquote best-in-class durable polymer DES, such as the platinum chromium EES, Xience, and the Resolute platforms. So to compare them head-to-head in a complex cohort and see what happens with respect to target lesion failure. And here are the results. You can see no differences in target lesion failure. So the biodegradable platform does just as well as a durable platform. We see no advantage, but certainly we see no penalty. And again, we see with respect to bleeding, large reductions in bleeding. And again, as we've seen in the other subgroups thus far, we see no penalty to be paid with respect to thrombotic events. So those are the sub-studies thus far, both pre-specified and post-hoc that we've presented. And with that, I will let Mauro go, and I can stop sharing.
Oh, well, thank you. Thank you so much. If you stop sharing, and I will share now.
I'm off
the screen with everybody. So can everybody see Mauro's? Can you all see that, or?
Yes, Roxana.
We're good.
Okay, great. Yeah.
Okay, good morning, everybody. Thanks to Dr. Mehran for the introduction and for the opportunity to present personally the results of our study. Well, a brief introduction. Collectively, atherothrombotic disorders of the coronary, cerebrovascular, and peripheral arterial circulation are the leading cause of death and disability worldwide. Several real-world registries showed how their prevalence is increasing, and better means of prevention are urgently needed. Of note, atherosclerosis progression and ischemic events share common pathophysiological pathway in different arterial territories, and is extremely common in clinical practice to see patients that experience ischemic events, two or more ischemic events in different arterial territories. Both the European and American guidelines recommend long-term use of antiplatelet agents in patients needing for secondary cardiovascular prevention, and aspirin is the drug of choice in this relevant population. Nevertheless, other antiplatelet agents have been evaluated in this setting, such as the inhibitors of the P2Y12 receptor. And as shown by several studies, the inhibition of the P2Y12 receptor could be more effective than inhibition of the cyclooxygenase in terms of reduction of hemostatic system activation. But despite this preclinical observation, only a few trials directly compared the P2Y12 inhibitor monotherapy and aspirin monotherapy in patients with established atherosclerosis. And of note, the results from these trials were often varying. For this reason, we performed the systematic review and meta-analysis in order to provide a comprehensive synthesis of effect estimates and quality of evidence. And we included all trials that directly compared P2Y12 inhibitor monotherapy and aspirin monotherapy for secondary prevention in patients with established atherosclerosis. The pre-specified primary efficacy endpoints were myocardial infarction and stroke, while the pre-specified key secondary efficacy endpoints were all-cause vascular death. The pre-specified secondary safety endpoints were any bleeding and measured bleeding. Every outcome was adjudicated according to the original study protocol definition, and strokes were considered of ischemic origin, unless otherwise specified in the original study protocol. In the next slide, I tried to summarize our statistical methods, but I just want to cite the subgroup interaction and sensitivity analysis that were performed in order to assess if there were any impact on our effect estimates by the type of P2Y12 inhibitor, by the qualifying disease, by the aspirin dosage, time to index length from enrollment, length of follow-up, and even to non-event ratio in the control group. We also performed a sensitivity analysis, adding the results of the global leader one-year landmark analysis, because after 1 year, all patients in the two arms of this trial were treated with monotherapy or with ticagrelor or with aspirin. After database search and the so-called backwards snowballing, after abstract and full text screening, we included a total of 9 trials that were published between 1989 and 2020. Of note, many patients enrolled for cerebrovascular disease, for example, and also coronary artery disease, and vice versa. And this confirms that many patients could have 2 or more ischemic events in different arterial territories. Our main findings are reported here, and we can see that patients treated with P2Y12 inhibitors and aspirin have a similar risk of stroke, all-cause death, and vascular death, while we found a significant, although marginal, risk reduction for myocardial infarction. Of note, the number needed to treat was 244, and at sensitivity analysis removing the CAPI trial, this reduction was no longer significant. We found, as we can see in this slide, yes, no interaction between the P2Y12 inhibitor and treatment effect, as well as for the qualifying events and for all the other mentioned variables that we evaluated in the regression. Similarly, the sensitivity analysis, adding the data from the global leaders one-year landmark analysis, showed the results that were consistent with those observed at the main analysis. Regarding the risk of bleeding, there were no differences in terms of any bleeding and measured bleeding, while as it could be foreseeable, we confirmed that the risk for gastrointestinal bleeding is increased in patients treated with aspirin compared to those treated with P2Y12 inhibitors. In conclusion, our study shows that compared with aspirin monotherapy, P2Y12 inhibitor monotherapy is associated with a lower risk of myocardial infarction and of a comparable risk of stroke. Nevertheless, the benefit favoring P2Y12 inhibitors among patients with established atherosclerosis seems to be of debatable clinical relevance, considering the high number needed to treat and the lack of any benefit in terms of all-cause and vascular death. And thanks for your kind attention.
Thank you so much. We'll now go to the panel discussion, and we have a fantastic panel here. And first and foremost, I want to introduce to everybody Giulio Stefanini. Welcome, Giulio, from Humanitas Cardio Center, and thank you for being here. And congratulations on this wonderful analysis in the Lancet, just published, I think, almost a week ago or 2 weeks ago. And we're very, very proud that you're here with us. Do you want to tell us what the significance of this this meta-analysis is for our clinicians who are, and what's the take-home message? Should they now, based on your meta-analysis, switch their patients from aspirin to a P2Y12 inhibitor?
Well, thank you, Dr. Mehran, for the invitation. It's a true pleasure to be here to discuss these data. As a matter of fact, I think that this analysis informs secondary prevention in a very broad way, in the sense that we have a very large number of patients that do have evidence of atherosclerosis and are on secondary prevention with an antiplatelet agent, which according to guidelines is mainly aspirin. It's not about the post-PCI period. It's secondary prevention on the long run. And what we observe in this very broad population with very heterogeneous cardiovascular risk profiles is that, according to our evidence, the marginal benefits that is provided by a monotherapy with a P2Y12 inhibitor is probably too marginal to justify a replacement of aspirin therapy in the very broad population. However, there are two issues that I think. First of all, our data do not actually focus on the post-PCI period, so they are somehow complementary to the Twilight data. Since the Twilight data tell us that a monotherapy with a P2Y12 inhibitor, specifically ticagrelor, is a very valuable option as an alternative to DAPT for the first 15 months after PCI, but what to do beyond that time point? On the other side, I have to say that our evidence looks at average effects on the broad population, and it might well be that specific high-risk subgroups have a way more pronounced benefit in terms of a therapy with a P2Y12 inhibitor as compared to aspirin. And that answer can only come from a large scale randomized control trial or from at least an individual patient data analysis of available evidence.
Thank you. Thank you so much. I think that's a really, really important takeaway. We have an astute panel here at Mount Sinai, Dr. Fuster, Sharma, Kini, Stone, and Dangas. Maybe I can ask Dr. Fuster to give us he's the really, truly a legend in antiplatelet, anticoagulation, antithrombotic therapies. Dr. Fuster, what is your take on P2Y12 inhibitor monotherapy after all of these data that are now being published?
Well, first of all, monotherapy is a priority. Let's start here. The question is it working? And I divide the patients in three groups. One is the atherosclerotic disease, just presented very nicely, in which, in general terms, to overcome aspirin is not simple. And actually, economically speaking, there is a significant difference. Then there is the patient at high risk, and I'm talking in general. Then there is a patient at more risk with acute coronary syndrome, and then the patient at more risk with complex disease. In these groups, there's no question that ticagrelor, you, Usman, Dangas, have demonstrated, and we have the papers in JACC, which I did an audio of that really ticagrelor alone is a way to go, or certainly is a very important. What I have is two questions. Question number one, for how long? Because there are patients who have tendency to bleed, and still you could give it for 6 months. There are patients who do not have a tendency to bleed. Maybe you could go on forever. So that's the first question I have. And the second question is, there are other alternatives for monotherapy that actually are not ticagrelor. And here comes the issue of NOACs, is number one. And then the issue of clopidogrel alone, if you're really dealing with patients that perhaps are not in a very high risk. So the three questions are, for how long, number one, number two, NOACs, and number three, clopidogrel in the relatively low risk population.
So those are really, really excellent questions. And what I want to do is make sure that, first of all, as you know, in Twilight, we only studied the monotherapy for 1 month. In Global Leaders, they looked at it for 2 years, up to 24 months after a month of aspirin and ticagrelor, showed very similar findings to us. So with ticagrelor, I think we can say that. With other antiplatelet regimens like P2Y12 inhibitors like prasugrel, the potent one, there's not been evidence of monotherapy in the way that we have collected. This is a different P2Y12 inhibitor. It's irreversible compared to ticagrelor that has a reversibility. I'm going to ask Dr. Sharma about that and see what he's doing with his patients. And he's really the person who helped us design this study. That was one of his ideas about withdrawing aspirin and going, because he was treating his complex patients with ticagrelor. And then the NOAC monotherapy is a very interesting one. As you know, in COMPASS, for prevention of cardiovascular events, the rivaroxaban alone did not have the statistical significant reduction, but that was an early stop of the trial. So it's possible that if you go to a NOAC alone, that you could gain that kind of a benefit. But you know that the best winner there was low-dose rivaroxaban in combination with aspirin. So let me turn to Dr. Sharma to help us answer these questions from Dr. Fuster, because Dr. Sharma is also on the executive committee, and Dr. Kini and Dr. Sharma helped us bring this to the next level, and I really want to hear their clinical takeaways. Dr. Sharma, Dr. Kini?
Yeah. Good morning to all, and just want to emphasize, as you mentioned, that the whole concept, most of the, right now what we do, we add medicine to improve the care. And with the Twilight trial, you really have shown that maybe sometimes you cut the medicine and may still have a better results. And this is really remarkable, which you did. And as Dr. Mehran mentioned, that when he joined us here, it was my practice back then, 2010, 11, 12, so any patient with a bleeding risk, and particularly they were taking prasugrel or ticagrelor, used to stop aspirin between 1 to 1 month, means 1 month was the usual time period. And clearly we had a lot of discussion. He said, well, it's a clinical practice, but there was no data. But I knew in my own practice, this combination did extremely well. No issue with the ischemic, and definitely decreased bleeding. And I'm really thankful to Roxana that really brought this concept to light so much that hopefully will be incorporated in the guidelines. And this is a phenomenal trial which was done and has taught us a lot of things, that irrespective of your complexity, your diabetes, the signal therapy after 1 to 3 months. I know global leaders did a 1 month, but that was, and more important, that careful done trial with adjudicated endpoints will really change our interventional therapy post PCI. And that is to abbreviate the duration of aspirin and continue ticagrelor in these patients, even in stable high-risk CAD. So really thankful for that. And I think multiple publications coming out of it, and there's no end to it, because simple message, irrespective of the CAD severity, your clinical presentation, maybe STEMI were not part of it, but in most of the clinical presentation, ticagrelor alone does the great job of continuing same, reduce ischemic endpoint, but more important, reducing the bleeding. And really thank you, Roxana, for that.
Well, thank you. Dr. Kini, Dr. Dangas, and then I want, obviously, Dr. Stone's input as well. What do you think that these data are transferable to clopidogrel and prasugrel? Because that's a very, very big question. And what are you doing in your clinical practice, Dr. Kini or Dr. Dangas? Either one. Dr. Kini?
Is she on the line? No, I think she was not on the line, but I can just tell you, of course, we'll hear their opinion. We are not done routinely with clopidogrel, but used to do, and even now, routinely with prasugrel. I know some laboratory data did show the same way, that adding aspirin on prasugrel doesn't add to additional platelet inhibition, and we know that that could be harmful from bleeding. But yes, not done for clopidogrel alone, but definitely I would say that in the clinical practice, I know we don't have the trial like Twilight, but clinical practice, I have no hesitation to take away aspirin, just like we are doing it in the based on the Twilight for the ticagrelor.
Well, based on the pharmacodynamics of the whole situation, in order to follow this concept, you have to have a potent P2Y12 inhibitor. So with clopidogrel and another resistance upwards to a third of maybe half the patients, I don't think that's a good and straightforward situation to do it. However, the prasugrel might be one to really, be hopeful. And could there be a study with 10 milligrams of prasugrel? That might be also a clue to reduce bleeding complication with these agents. As we know, there have been quite a few problems, particularly also in the elderly and previous stroke patients in this categories. So there's a lot to be gained by a monotherapy with prasugrel if there is a study about it.
If I can add something, Dr.
Yeah,
Mehran,
go ahead, Giulio.
I think that what comes very much out of this discussion is that it's truly about tailoring the right therapy on the right patient. And Twilight somehow brings us information in that sense, since you identified a very defined population and you show that in that population there is a benefit with a ticagrelor monotherapy. I found very interesting the comment of Dr. Fuster about the possible role of NOACs. As a matter of fact, Mauro, just a couple of years back, published a nice meta-analysis in JAMA Cardiology, in which the role of NOAC was evaluated according to the type of acute coronary syndrome, showing a potential benefit in ST elevation MI patients. So also there, I think that it's truly about to select the right population for the right drug.
No, that's a really, really good point. I'd like to hear Dr. Stone's input on the questions that Dr. Fuster always asks, the hardest questions. For how long are you convinced with these data, especially on this meta-analysis? Dr. Stone?
Sure. Hi, Roxana, can you hear me?
Yes, you're good.
Yeah, we hear you.
Yeah,
we hear you great. Thank you.
So great presentation. So of course, congratulations on Twilight, which was a fabulous study. You know, so in terms of first switching from ticagrelor to prasugrel, would the results be interchangeable? As has been mentioned by everybody, we don't have a trial, but given the similar pharmacodynamic potencies and given the results of ICAR-REACT 5, which if anything finds a benefit for prasugrel, as long as you've got the right patients, and that is patients who are not markedly elderly, not a very low body weight, and certainly don't have prior stroke or TIA, then I would suggest that probably prasugrel would be equally effective. You know, whether you should do that or not, given the absence of clinical trial data, is another story. In terms of clopidogrel, I do not feel the same. Clopidogrel is a much weaker P2Y12 inhibitor, and given the CYP2C19 polymorphisms, you're going to have up to a third of the patients, depending on the race, that's going to be hyporesponsive, and as many as 5 to 10% that will be aresponsive. So that's a different story. We also don't know yet. You excluded STEMIs in this trial, so we're not sure about STEMIs or other ultra-high thrombotic risk situations. And in terms of the switch to the NOACs, I was very impressed with the COMPASS data, but of course they excluded patients who were on a P2Y12 inhibitor. And we still have pretty good data for P2Y12 inhibition through 12 months. And as you said, Roxana, the data in COMPASS was strongest for aspirin and low-dose rivaroxaban. So we get into a very confusing thing. Do you do aspirin and ticagrelor or prasugrel for 1 to 3 months, then go to ticagrelor alone or prasugrel alone up till 12 months, and then at 12 months, do you switch to aspirin plus low-dose rivaroxaban, 2.5 BID? That would be one possible scenario that would be data-driven, although it seems a little bit clumsy. And could you continue the P2Y12 inhibitors beyond 1 year? Well, really, the only decent data that we have was that from the Pegasus TIMI 54 trial, which showed, you know, again, with low-dose ticagrelor beyond 1 year, especially when you continue it without an interruption, it seemed like it was pretty reasonable, but the bleeding complications, you know, were substantial in that study. And
but
that
if
was,
you remember, Greg, Pegasus was with aspirin. The only one that we have data on is, the only data we have actually is with global leaders beyond a year, because they went to 2 years of ticagrelor monotherapy. And they did show the benefit, but obviously they didn't meet the statistical significance because of the way they collected the data. But what my thoughts are, what do you think about the meta-analysis that Mauro and Giulio Stefanini presented here today? The one in the Lancet, really showing that in patients with atherosclerotic disease, P2Y12 inhibitor monotherapy, based on the data that they collected, was protective for myocardial infarction and stroke.
Are you talking for primary prevention or secondary prevention? Secondary prevention with established atherosclerosis?
Yeah. and I'll show you I don't know if you were not on, but I'll
Yeah.
show you it was just now, they just showed this was the monotherapy, the meta-analysis that Mauro just presented. And as you see, there was their key co-primary endpoint of stroke and MI was in favor of with the numbers needed to treat of 244. But importantly, you can see here there was no interaction between the P2Y12 inhibitor and treatment effects, and they really had a really nice conclusion showing that P2Y12 inhibitor monotherapy was associated with lower MI and comparable risk of stroke. What do you think about that? Should we go to P2Y12 monotherapy? Is that a debatable
You mean for long-term use?
issue?
Well,
Yes.
you know, I did read this meta-analysis. There's obviously a lot of limitations in terms of the types of the studies, limitations of the individual studies. Even though they didn't find a difference in the P2Y12 inhibitors, I'll be honest, I don't believe that. I'm more strongly influenced by the COMPASS results, where they actually had a mortality reduction. And of course, in patients with peripheral vascular disease, the results were profound. So at this point, I'm a little more influenced by a single 25,000 patient, double-blind, randomized trial
and I think,
showing a reduction in mortality with NOAC after 1 year.
that would be great. And I think that there are future trials that are going to be focusing not on stacking, but rather going to a monotherapy based on all of these data. I think it's really creating an important issue. Are there any questions? I think there's some came through the chat. Should we look at that, Dr. Goldman? Are there questions that we should make sure we address by our people here?
No, there weren't any in the chat, but if you could address, Dr. Stone brought up the issue and Dr. Fuster about, earlier DOAC and antiplatelet agent as a potent combination. Should that be looked at earlier on after 3 months as a long-term strategy rather than, having a strategy of 3 months, then go on for 9 months and then another one subsequently? And also, what's the duration of therapy in these patients? A year, 2 years?
So I think you bring up a very, very good question, Dr. Goldman. And the 3 month was not so arbitrary because we were actually including all comers, ACS and stable coronary disease. And what we were doing, and Usman could attest to this, is that it was really difficult early on to get people to actually enroll patients and get IRBs to approve any kind of a withdrawal of aspirin after complex PCI. It was like a very difficult study to get off the ground. You have to know that. And so the 3 months was sort of a place where people felt comfortable. We had a lot of discussions with Dr. Sharma. He was ready to stop at 1 month. And I think we're learning that we could probably do that, but the 3 months is a very good place. I think in those patients who are at really high risk for bleeding and whom you want to give a potent P2Y12 inhibitor, maybe even 2 weeks or 1 month of dual therapy and then going down. It's really important to have a very good PCI with good stent expansion, a non-complicated procedure. In other words, no reflow, no dissections, no issues in the intra-procedural part. And I think once you get a good result, you could go even lower. For how long you go for the P2Y12 monotherapy, it really is a patient-related aspect, and I think that's something that we have to address. In the chat box, I see a question. Was there an increased stent thrombosis in patients who had stents less than 2.5 millimeters in diameter? Usman, do you want to answer that? Because I know you did that analysis.
Yeah, so thus far when we've looked at any complex, sort of categorization, either pre-specified or post-hoc, we haven't seen any incremental risk. We haven't formally just looked at that small vessel on its own. I think our mean, the minimum stent diameter average minimum was about 2.8 to 2.9. So the proportion of patients with a 2.5 or less is going to be extremely small to look at. But thus far, there's been no signal of excess thrombosis, even when we looked at different angiographic criteria.
And then lastly, a very good question. Can they reduce the ticagrelor dose to 60 milligrams or go to clopidogrel alone? And I would say clopidogrel alone, I'd be very nervous about. We heard that already. Ticagrelor 60 is a choice, but we didn't study it in a monotherapy. No one has studied that with a monotherapy alone. So I would be against that unless it is studied. Usman, do you agree with my answer? I want to make sure that everyone agrees to that. I think that's where I would stand.
Right.
Dr. Sharma? Dr. Sharma, would you go to a 60 milligram ticagrelor and feel comfortable?
Definitely, yes.
Okay, that's Dr. Dangas, and Dr. Sharma must be off already. Okay, well, I mean, we didn't study it, so I would say no. So Dr. Goldman, this has been a wonderful, we're right on time. It's exactly 9:02, and I want to really thank you and everyone who joined. This has been wonderful to have a highlight on Twilight, so thank you. And thanks to our guests. Mauro is not a guest, he's our fellow. Mauro, you're in Milan, but we're very close, and we're looking to get you back here. Dr. Stefanini, thank you so much with your very difficult time. I hope that you get to get a haircut soon. It looks like that the haircut places aren't open yet in Milan. And I want to thank Drs. Fuster, Sharma, Kini, Dangas, and Dr. Stone for their comments. Thank you all again. Thank you.
Roxana, can I have a final comment?
I just
Can I
answered
have a
a
final-
survey
Of course,
about
Dr.
my internet capabilities for CRF.
Yeah, my final comment.
do that?
Dr. Stone, can you mute yourself? Thank you.
My final
All
comment.
right, go ahead, Dr. Fuster.
First of all, I have to congratulate you guys, the investigators. It came up into the monotherapy approach, and it's wonderful. It's so good that we can go simpler and simpler. But also a point that is important to realize that 2/3 or 3/4 of the world cannot afford what we are talking about. And I think it's very important that we pay attention, that we are really talking about people who can afford all these drugs. But unfortunately, we have a problem. I just wanted to bring this up, but I want to emphasize the work you guys have done.
I just wanted to echo what a tour de force this was, Roxana, putting this on today, but more importantly, the years that you and your colleagues, Dr. Baba, Dr. Sharma, Kini, and Dangas, this is a tremendous amount of work. We'll have to do one journal club, just you're describing the efforts to put this type of international study together in the years, but I think it paid off so well in what you've taught the international community how to treat patients. We look forward to more of your presentations. Thank you all very much. Have a great day. Thank you, our Italian colleagues, so much for joining us today. Have a great day. Be well. Thank you.